So again, welcome. Thanks so much for being here. It's interesting. So we have people at both ends of the spectrum. We have people who are just coming to learn about this diagnosis, and we have people who are quite experienced and have multiple family members. So we'll start with a little bit of the basics here, but in the end, happy to discuss at any point to make this sort of an informal discussion. I'll put you guys to sleep otherwise if we just roll through slides, so I hope we don't do that. But anyway, this condition we're here to talk about today, Chiari type 1 malformation, I think most, of course, you all are aware that the classic way we think about this is the position of the tonsils of the cerebellum, which of course is that area at the lowest part of the brain there. When those cerebellar tonsils descend below the base of the skull, and the exact measurement is a little bit arbitrary and controversial, so we'll just use, for the purposes of discussion, I guess the most common definition or most common interpretation of that, which is 5 millimeters. The reason I point that out is that some of the studies that we'll talk about use that 5 millimeter rule, but I do want to just say that there are shortcomings with the 5 millimeters. It was based on a limited number of patients from the first MRI scan study back in the 80s. Another thing just to talk about is sort of how Chiari malformation is sort of classically presented. And when we get to the end, I'm going to tell you that I think that the classic presentation is uncommon and probably only applies to a certain subgroup. But nevertheless, the classic presentation is sort of these headaches. They're headaches that are at the back of the head. They tend to be worse with a cough or a sneeze, and they tend to be pretty quick on and off. So what we typically think, and if you look at the definitions of Chiari-type headaches that are available in the neurology literature through headache specialty societies and so forth, it's really headaches that last less than 5 minutes. Now, I do want to say headaches are complicated, so I don't want to get too caught up in that particular presentation, but it's important to recognize that's what most neurologists, most neurosurgeons think about. Headaches, back of the head, worse with a cough, short in duration or fleeting. But of course, there are all sorts of other symptoms that we see. Of course, in this bottom right here, you can see a partial listing here, fainting, visual changes, weakness or sensory loss, swallowing or speech difficulties, balance difficulties, and then a lot of these are related to syringomyelia or syrinx, which we'll talk about too. There are many different conditions that are associated with Chiari. I'm going to actually expound on this a little bit later, but just know that there are many different ways that this can kind of come to the forefront. Syringomyelia, which is essentially when a small cavity can form inside the spinal cord and fills with fluid. Syringomyelia or syrinx, some people will say for a shortened term. We don't really understand how common or rare this is when we think about syrinx just generally, but it's very common in the setting of Chiari, and probably Chiari is the most common way that we come to discover syringomyelia. And syringomyelia is associated with neurological problems like sensory loss or weakness, spinal cord type symptoms, which we call myelopathy, and I'll comment back on that again later. And then chronic pain or sensory loss, and then scoliosis or spinal deformity. And it turns out, when I earlier said, a lot of people come to us with headaches, many other children will come with scoliosis and syringomyelia, and we find the Chiari secondarily. So sort of to kind of just for a moment say that not everybody comes to our attention because of headaches. Now, there are a couple of alternative designations other than Chiari type 1, and so I just thought for the purposes of sort of calling them out, we could go through them just quickly here. So one that we see very commonly is called the Chiari 1.5 malformation, and this is when you have that cerebellar tonsillar protrusion through the base of the skull, but also part of the brainstem is herniating down as well, or is lower than the base of the skull as well. And that's sometimes marked by this little notch here called the obax. So when you see brainstem and tonsillar displacement through the base of the skull, we call that Chiari 1.5. So why is that important? It's important because these patients tend to be a little bit more refractory to some of the procedures that we use to treat Chiari. The response to the typical treatment, which is this Chiari decompression or posterior fossa decompression, tends to be less robust and sometimes needs to be revised. So definitely something to think about that is among these more complex Chiari diagnoses. There's another one called Chiari 0. And Chiari 0 has been described when you have syringomyelia, or that syrinx, but without cerebellar tonsillar displacement down into the cervical spinal cord. This is an uncommon presentation. This was described by the group in Alabama about 12, 13 years ago. And it's important because we do see syringomyelia in the absence of tonsillar ectopia, but it's a complicated diagnosis to come to. I'm happy to talk about it or comment on it further, but just know that it's unusual. There's a Chiari 0.5. You can see the theme here, right? There are integers or half integers here. A Chiari 0.5 was described a few years back by Jeff Greenfield up in New York. And just to show you here on this MRI scan, Chiari 0.5 is when these cerebellar tonsils kind of wrap around the brainstem, usually about halfway or beyond around the brainstem. And Dr. Greenfield has described this, and it's another diagnosis that we think about where the cerebellar tonsils may not be as far down, but can be symptomatic and may benefit in some circumstances from surgery. You know, I've been fortunate to help with a lot of the research in children around Chiari and syringomyelia. A lot of it was done with this group called the Reeves Syringomyelia Research Consortium. And the reason I mention this is that this was formed kind of at the beginning of when we began to think about multi-center research in Chiari. And so this was the total cohort of institutions that participated in a lot of these different studies. So it turns out to be 42 centers across North America. And we were able to use the power of all those surgeons working together, and they were mostly surgeons working together, to accrue or accumulate data on Chiari and syringomyelia in the way that we could make unique observations, not as one-offs or two-offs, that kind of thing, but really using big numbers to understand this condition more thoroughly. One of the things that we thought about early in the investigation of Chiari and syringomyelia is how do we measure it? And it's funny, we had a discussion this morning in our department here about this. How do we measure our successes and how patients do over time? And it turns out early on we just used the physician's gestalt. That was the only way that we knew to essentially judge how our patients did. And over time we began to use standardized scales. One would be the SF-36, for example. And then over time people began to develop Chiari-specific scales. And that's when we started to really focus on health-related quality of life, and not just how the surgeon, for example, thought somebody did, but how did they actually feel? How did their parents feel like they were doing? Were they, for example, able to go to school, to work? Did they graduate from high school? These sorts of things. And that was really a major leap forward, to essentially use patient outcomes in the way that we think about in measure the way we do our treatment for Chiari and syringomyelia. This was one of these, the CSI Chiari Severity Index, was an early predecessor of how we thought about patient outcomes. And I'm going to actually not go through this in too much detail other than to say using these really advanced statistical methods, we began to predict outcome in how a patient thinks about how they're doing. And then our colleagues from Vanderbilt, Shevis Shannon and Travis Ladner and Jay Wellens, developed the so-called Chiari Health Index for Pediatrics, or the CHIP. And the CHIP was an interesting tool. It was devised completely for Chiari and Syringomyelia, and it looked at pain, pain frequency and severity, and then non-pain symptoms. So numbness and tingling, dizziness, and not just these sort of physical symptoms, but also psychosocial aspects as well, like the ability to attend school and as I mentioned before. And it does turn out that the CHIP was accurate in being able to measure and predict how patients would do with surgery, for example. And it, again, was such an innovative and unique way to assess not what the surgeon is thinking, but what the patient is thinking. So this was a major step forward. I'm going to stop there for a second, because I feel like I'm talking too much, so I want to see, does anybody have any questions or comments? It's late in the day, and I want to make sure I'm not droning on here. Okay. All right. So, you know, one of the things that we did through this big database is we could finally look at how the treatments affected not just the very common treatments affected our patients, but the ones that were needed less commonly. And so this was one study that was conducted by Travis Creve-Coeur and Gabby Johnson. Travis is now a senior resident at Columbia in New York. And what they found is that when we think about the complexity of craniovertebral junction structure and how it changes over time, you know, one of the things that we think about very commonly is whether somebody has instability. And this is a very kind of controversial topic in our field. And the reason you know, I wanted to show this is that at least in the Park-Reeves database, the patients that actually went on to get a fusion were relatively uncommon. So it was about 2.5% of these patients ended up going on to receive fusion. Now, needing fusion and receiving fusion are two different things, and the way that the database was, we could only look at those who received fusion. So I do want to make that point. But it's important that...
So I read that before. I thought it was really interesting that for a while I measured all the angles.
Yeah.
I didn't actually know what I was doing when I did it. But how often do you use it? Because I found I wasn't using it.
Yeah, I would say that I think I've gotten over time. I look at more than just cerebellar tonsillar position. So I'd say almost every patient I see, I look at the clivoaxial angle and the PBC too. Yeah, no, I think I generally measure it, and I'll even include it in my notes most of the time. And basilar invagination, all those things, I do try to take a close look at it. But the key thing is that in children, at least, the percentage of patients that needed that fusion was low. But you could usually tell it, at least in this population, by looking at those angles that Dr. Ritter just mentioned, the clivoaxial angle, and then also basilar invagination. It was about this time that Dr. Brockmeyer, Doug Brockmeyer from Utah, coined this term complex Chiari. Now, complex Chiari essentially refers to those patients who have things like Chiari 1.5, which we talked about before, or basilar invagination, or a very acute angle of the junction of the head to the spine, so that acute angle of the CXA, or clivoaxial angle. But I would say that even though this was an important effort and it showed that it was uncommon, for people to need these advanced skull-based procedures or these advanced fusion procedures. You know, we really felt like we couldn't adequately predict this, who was going to go on to need that, and the reason I point that out is we are working towards that now. My colleague, before I left St. Louis and came here to Richmond, Dr. Jennifer Straley, conducted this study through Park Reeves where we tried to get at that question that I mentioned before. So some children present not with headaches, but with scoliosis. And when they have scoliosis, very often they have syringomyelia. So Chiari, Syringomyelia, and spinal deformity. And one of the things that she tried to get at, Dr. Australia, was can we predict the course of spinal deformity with Chiari treatment, essentially? And it was a really interesting paper. What she showed is that those who had a Chiari decompression in the setting of scoliosis and syringomyelia were more likely to have stabilization or improvement in their curve if they had surgery at a younger age. And it was, let's see here, holochord syrinx and then syrinx length were both predictors of having scoliosis. And it turns out that younger age at the time of Chiari decompression was associated with stabilization or even an improvement in that curve. Another paper that we essentially, or another study that we conducted was around looking at syrinx regression. Now, remember that there's Chiari and then the syrinx. That syrinx is that cavitation or fluid accumulating in the spinal cord. And the question is, if we reason that fluid in the spinal cord is not good, which is true, and we do Chiari surgery to help treat that, are there things that we can do, different risk factors that we can identify to predict an enhanced improvement in syringomyelia? And so this was a paper looking at that question, and this was Andy Hale, who's now a resident at University of Alabama, Birmingham. And what he identified is no matter how you looked at syrinx regression, and it can be defined in a number of different ways, so reduction in syrinx size, let's just say, the best way to treat it in this particular study is to treat it early. So in people who were treated earlier and people in this study that had a duroplasty operation were more likely to have a response in terms of their syrinx to surgery. And if we think about duroplasty, one of the other studies that was conducted here, and this was by Dr. Alex Yahanda, who's a resident at Washington University now. What he said is, okay, well, duroplasty we know is likely to have an increased risk of complications. Are there different things that we can do in the duroplasty to reduce the rate of complications? And so he looked at different graft types. And it was actually very interesting. What he found was that when he compared pericranium, which is a patient's own graft material, to other graft types, so non-autologous graft types like that made from cadaveric tissue or from bovine tissue or from synthetic material, the complication rate changed based on the different graft material. Such that those patients who were treated with autograft tended to do the best in terms of minimizing complications in comparison to those that had synthetic grafts or other types of graft materials. The one exception was this alloderm graft material, which performed nearly, at least statistically, as well as the autograft. But other than that, many of these other materials actually resulted in a higher rate of complications. So this is something that, for sure, I've integrated in my practice and I've shared with many surgeons because it does turn out that the graft material probably plays a role in some of those complications that we see. And then, you know, we talk about the surgical treatment of Chiari malformation. You know, this question of duroplasty does come up. Is there something other than duroplasty that we can do that can minimize the rate of complications. So this is a paper that was published by a group from Oregon, led by Dr. Nate Selden, where they said, okay, can we do something other, less invasive than duroplasty? And so they developed this technique, which is an extradural technique, meaning they don't open that layer that contains things like the cerebrospinal fluid. Instead, they strip the outer layer or split the outer layer of the dura, which is duplicated in this area, away. And what they advocated for is once the outer layer is stripped, you're left with a very thin, actually almost even see-through membrane there where you can appreciate the cerebellar tonsils pulsating. And they felt like that this performed well in terms of the response of patients to surgery. And so this brings up this question that is the most vexing problem in the management of Chiari and Syringomyelia in children for sure, and that is whether or not to do this duroplasty, to take those risks on in hopes that the treatment will be more durable, meaning will last longer or will result in a reduction of symptoms or a better response of syrinx. So really this is the question that has been around for many, many years. It's been studied in meta-analyses. These are papers that assemble all the available medical literature. And this has been done for over 20 years now. And essentially people, I think, believe, without great levels of data, they believe that the duroplasty operation, which is PFD, duroplasty, posterior fossa decompression with duroplasty, is associated with higher rates of neurological complications, cerebrospinal fluid leak or wound-related issues, and longer time in the operating room. But it may also be associated with a higher rate of clinical improvement or syrinx resolution. And so we have studied this in Park Reeves, and it did turn out that at least in this paper that was not a randomized controlled trial, that posterior fossa decompression without duroplasty had shorter operative time in blood loss, that's not a surprise, and fewer complications. But the duroplasty operation in this particular study was associated with better symptom improvement, a better reduction in syrinx size, and lower revision surgeries. That kind of is what we learned from these meta-analyses. And time and time again, individuals will call for a randomized control trial on this issue. So we ended up, actually, and this is where I plug Bobby Jones CSF. We actually submitted a grant with Bobby Jones, and they served on our patient advocacy committee. We requested and were awarded funding through a group called PCORI, the Patient-Centered Outcomes Research Institute. So along with our patient advocacy partners, we did propose and conduct a randomized controlled trial looking at this question about whether or not to perform duroplasty in hopes of lowering the complication risk. That's number one there. Maximizing symptom relief and syrinx resolution, and then providing the highest possible quality of life for individuals. And so the idea behind this is to provide high quality data and reduce our reliance on low quality studies. And this was obviously very, very complicated trial. It was over 38 different centers, and with lots of different components to the study, and the primary outcome was at 12 months, but we continue to follow these patients even now. And I want to point out Tanda Meehan, who has helped me conduct this study along with the rest of the Park Reeves investigators, and then Tammy Bethel Anderson, and then Ashley Roberts also, who've helped with this study over time. So the long and short of it is that The results are embargoed right now, so I can't actually share them with you, but I really feel great about this study that we're finally going to address that question in a way that is going to directly impact our patients. So anyway, thanks to everybody, and especially to Bobby Jones for helping us do that study. So I'm actually just going to kind of show a few cases here. And what I'm going to try to say is that all Chiaris are not the same, and I want to see if I can convince you of that. So this is a 10-year-old male, daily occipital headaches, and they underwent a posterior fossa decompression with duroplasty. So 10-year-old male, occipital headaches. And then you can see the tonsillar ectopia here. This is, the obex is down here, so this would be roughly approximating a Chiari 1.5. So contrast that with this child who is a 4-year-old male with occipital headaches, but hypermobility as well. And so what I'd like to show you is that the tonsillar anatomy does have a different appearance here. And so there are differences in what we call Chiari malformation, and that's what I'm hoping to convince you of. And here's another example of this. This is a 14-year-old male with no headaches and presented with spinal deformity. We already kind of talked about this a little bit. But what we're trying to do now is, well, maybe I'll say one more thing. And this is a 6-year-old with a genetic condition called Pfeiffer syndrome who had multi-sutural craniosynostoses. That's where the bone plates fuse prematurely. And they underwent some treatment for that premature fusion of the sutures and ended up having some abnormalities related to compression of the brainstem. But clearly this is a different problem than what we saw in those others. So you can see this is a complicated craniovertebral junction. The part of this second bone in the neck is up and pushing along the front part of the brainstem there. So this is more along the lines of the complex Chiari. So the reason I point out these cases is that I think we're increasingly recognizing that this is complicated and that there are lots and lots of different presentations of Chiari. We didn't even talk about CSF leaks. Happy to comment about those, or venous hypertension. That's when sometimes the blood can be blocked as it's leaving the skull. Secondary Chiari malformations that happen oftentimes in the setting of shunting. And then, of course, Chiaris can occur from all sorts of other intracranial processes. The bottom line is that there are lots of different ways to think about Chiari malformation, and that's why it's so hard to understand how best to treat it. And that's why even here we think about, there are people that have traditional headaches, there are people that have hypermobility, there are people that don't need fusions, there are probably the people that do need fusions. How do we make sense of all this? One of the things we're doing is sort of looking at the genetics of this disease. And so this is Gabe Haller, who was my colleague at Washington University. He's a human geneticist, and Bobby Jones has helped us with this study as well, trying to get at the genetic variations that are associated with Chiari malformation, because they can give us insight into why it develops in the first place. I'll give you a couple of examples of that. So these are just 3 examples of children and related family members who developed Chiari malformation. You can see that Gabe has gone through and done the genetic pedigree here. And in this particular grouping, he looked at CDH8, at one particular gene called CDH8, and he found that these individuals had not just Chiari malformation, but they had macrocephaly. Their head circumference was high. Not from fluid overload, but just because their brain and their skull were larger in size. And so this particular problem, a CDH8, we've been able to use that novel genetic technology that I'm sure you've heard of called CRISPR, or CRISPR-Cas9. And we've been able to take that finding from a human gene and put it into a zebrafish and reproduce a Chiari malformation in a zebrafish. And so that is, in our mind, proof positive that this is causing Chiari malformation, or it's playing a role in the development of Chiari malformation. And others have sort of looked at, you can see this image of a zebrafish with spinal deformity as well. The interesting thing about this CRISPR-Cas9 zebrafish is they don't just have Chiari malformation like we talked about. They also, all their brain regions are larger. So it's really a condition of brain overgrowth rather than something that's just affecting the cerebellar tonsils. These are my colleagues, Jared Rowland and Nico Dozenbach, who've done this really, and Scott Merrick, who's not pictured here, really have done this groundbreaking research to use precision mapping of the brain using resting state functional connectivity in order to understand how Chiari affects the brain. This is really, I think, really interesting. We used to think that the cerebellum was primarily, almost exclusively involved in coordination and balance and these sorts of things, but using these precision cerebellar mapping technologies, we now understand that there are even some functions that map to the cerebellar tonsils. So in this particular image, you can see that the default mode network, it maps to the cerebellar tonsils. This is the area we generally think of as Chiari, for, of course. And so what is the default mode network and the frontoparietal network, which is also pictured here? The default mode network is associated with emotional control, and the frontoparietal network is associated with attention. So what we're trying to get at is sort of trying to understand the cognitive associations that we sometimes see with Chiari malformation. So this is really, really interesting stuff, and we have lots more that will be coming out soon on this. So what are we doing as physicians and investigators in this field? Well, I think number one, and I reference this, we really need to be able to improve our outcome measures. We really need to understand how our patients are doing after surgery and how is it affecting their quality of life, the condition and how we treat it. That's really, really important. So how do we define Chiari? I kind of started by saying that we don't really understand how to define Chiari. In order to define Chiari, in my mind, we need to understand the biology through genetics and brain networks. How do we treat Chiari? Right now, we've got one primary treatment, and that is doing a Chiari decompression, essentially making the box bigger. Is that the best we can do? I think we need to understand, by getting to the genetics and the different variations of Chiari malformation, maybe making the box bigger works for some people, but not everyone. And so, of course, what does this all mean for brain function, outcomes, and quality of life? And so I know that some of you in the room know that we have been studying a new way to think about Chiari malformation, getting away from even using that terminology of 1, 0.5, 1.52, and so forth, and thinking about using novel technologies, genetics, imaging, and machine learning to understand patterns in clinical presentation and clinical outcomes. And the next time we talk, I promise you we're going to talk about that. We have some really exciting stuff about the machine learning algorithms that we've been running, and understanding that in the noise of thousands of patients, we can actually see several subgroups that each have distinct presentations, meaning how they come, their symptoms, for example, and they all have distinct outcomes based on different treatments. So this is the first step for a precision approach to how we treat Chiari malformation. I'll stop there. That's enough. Yep.